Yeah, hi, welcome everybody. Thank you for joining us. So I am a geriatric psychiatrist and internal medicine physician, and I'm the medical director of a PACE program of all-inclusive care for the elderly, Providence, Elder Place, Oregon. And so disclosures, I don't have any financial disclosures. Off-label use of medications will be discussed because, with rare exception, there are no on-label medications for what we're talking about today. And funding for this program has been provided by the Central Oregon Health Council. We are accredited by St. Charles. So, learning objectives. I'm hoping you actually might learn more than just the objectives, but these are sort of some basic things. I want to describe the function of 4 common neurotransmitters. I think neurotransmitters are easily misunderstood, and so I thought that might help. This is the particular kind of area, neuropsychiatric disease, where they are really, it can be very helpful to have some understanding of them. I'm going to talk a little bit about several common neuropsychiatric illnesses, including Parkinson's disease, multiple sclerosis, and Huntington's. And then I'm going to really review treatment strategies for neuropsychiatric symptoms. And, you know, neuropsychiatry, sometimes I have a very simplistic view of things, and I say, well, neurology is like the hardware of the brain and psychiatry is like the software of the brain. It's really all the brain. And the reason it's the American Board of Psychiatry and Neurology is because sort of anybody can present with symptoms to either a neurologist or a psychiatrist for the vast majority of these diseases. And so I do want to just point out that what we know is that people who have quote unquote neurological illnesses, most of them have significant psychiatric symptoms, and that those symptoms are often one of the biggest contributors to decreased quality of life, disability, and they're very prevalent. And then the good news is that they can be targeted for treatment. They're not something one just has to suffer through with. So you can target and treat them if you have a knowledgeable provider. And this is specifically about dementia, but this is just one of the, if you look here, and I don't have a little pointer, but if you look here, you can see that the use of, the red line is dementia, the green line are people who don't have dementia in this very large data set of, I think about 60,000 people. And what we find is prior to the diagnosis, in the years starting 4, 5, 6, sometimes even 10 years before the diagnosis, people are being treated with antidepressants and antipsychotics, or anti-anxiety medicines or hypnotics for sleep use. So neurological diseases have definitions and are diagnosed using various criteria. But what we know is for many of those diseases, this is just one in particular, the psychiatric symptoms actually present prior to somebody meeting criteria for the disease. So these neurology and psychiatry are interlinked, interwoven, and it's very difficult to separate totally one from the other. So I'm going to talk a little bit about dopamine. So dopamine is one of the most important neurotransmitters, and it helps us pay attention. That's why ADHD medicines are target dopamine, but it's also important in lots of other illnesses. And the things that dopamine helps us with, it helps with our decision making, the little executive sitting behind the desk in our brain. if there were such a person. They help us, dopamine helps with motor control, it helps with motivation. The whole reward system in the brain that can go awry in gambling, say, or substance use disorders, that whole reward reinforcement system depends upon dopamine. And actually nausea. So like the most potent anti-nausea medications are actually antipsychotics because they target dopamine and the dopamine centers in the brain, which is one of the main places where nausea comes from. Serotonin, of course, I think this might be the most commonly talked about neurotransmitter. And we think of it as something that helps or hurts with mood, appetite, sleep, memory, and learning. So obviously pretty important areas for us: memory, learning, sleep. Norepinephrine, which is also sometimes called noradrenaline. So you hear sometimes people talk about the noradrenergic system. So that's norepinephrine. It's what targets and helps or harms with alertness, vigilance, formation and retrieval of memory, focusing attention, restlessness, and anxiety. GABA is what we call an inhibitory neurotransmitter. And it is, I think of it in many ways as kind of, it puts a little bit of a blanket around the brain and kind of mutes and slows the activity between neurons. And it definitely decreases the impact of dopamine. So it's not the opposite of dopamine, but it modifies the impact of dopamine in most of the places of the brain where dopamine is active. So GABA, it's always inhibitory. Glutamate, on the other hand, is always excitatory. So it sort of revs the brain up. It's quite important in learning, memory, perceptions. If you have too much glutamate, you might end up with seizures. If you don't have enough, you might end up with psychosis and coma and death in extreme circumstances. Acetylcholine is another common neurotransmitter, and we hear about that. There have been a lot of studies and a lot of press recently about anticholinergic meds. And so when people are talking about that, they're really talking about things that impact acetylcholine. So acetylcholine, see the choline in the word, that has to do with cholinergic. And so acetylcholine is what helps with arousal, alertness. It also is involved in the reward system. It helps us with sustained attention, you know, the difference between your eyes flitting from thing to thing and seeing what you're, you know, and focusing briefly to, say, when you're studying for the most important exam of your life, for instance. That's when you need your sustained attention at its best. And acetylcholine is involved in learning and memory. And so if you look, you will have already noticed, if you were listening, that there's a lot of overlap. And you know, there's a lot of different ways to break things down, and this is a little Venn diagram that is, you know, a gross oversimplification, as these kind of diagrams often are, but it gives you a sense, right? So mental alertness is really a dopamine, histamine, cognition kind of thing. Norepinephrine and acetylcholine has to do with vigilance. Serotonin and glutamate have to do with sensory, your senses, the five senses, and perception. And then things like attention, appetite, mood, and intuition, there are lots of different neurotransmitters that can have impacts on them. So these, when we talk about medications to treat neuropsychiatric symptoms, the medications we use usually work through one or more of these neurotransmitters. And what we're trying to do is modify these really complicated systems. And what I will tell you is I think we are sort of at a kindergartner, first grade kind of level in understanding the brain. I mean, it's just very complicated and it's challenging to study. And despite having, you know, hundreds of medications that work on these neurotransmitter systems, we still, I think, do not have a totally full and complete understanding. That being said, we have what we have, and we do our best to alleviate symptoms and modify disease progression where we can. So, Parkinson's disease. Parkinson's disease is really common, and you know, this data is from one particular study on prevalence of neuropsychiatric symptoms. There's lots of different ranges for these in different studies, depending on what population they looked at, how long people had had Parkinson's. So these are all ballpark kind of figures, but it gives you a sense of how common things are. So cognitive impairment, you know, is very common. 1 in 4 to almost 1 in 2 people have dementia if they live long enough. Depressive symptoms, nearly 1 in 2 people have depressive symptoms if they have Parkinson's. Suicidal ideation is quite common in people with Parkinson's disease. It's a disease that sort of that really impacts your ability to control yourself, and that really strikes home to many people and feels very, there's a lot of dysphoric feeling that goes along with that lack of control. Anxiety is very, very, very common in Parkinson's disease, and it's not nearly well studied enough. We know that there's an increase in specific discrete panic attacks in people who have Parkinson's disease, as well as an increase in situational anxiety. So in a particular situation where people are worried that their body or their brain isn't going to do what they want it to do when they want it to do it, that can lead to excess anxiety. Hallucinations, delusions, very common. Impulse control disorders, hypersexuality, excessive spending, pathological gambling, and executive dysfunction problems, repetitive behaviors, stereotyped and obsessive compulsive type interactions. So what do you do with these? So I'm just going to go over some symptoms and how they might present and how we might treat them. So psychosis, very common, between, you know, almost half, between 3 out of 5 and 2.5 out of 5 people who have Parkinson's will have psychotic symptoms. And this is even before we had medications for Parkinson's disease that can actually cause psychosis. Parkinson's disease itself is associated with psychosis. And you can see delusions, hallucinations, and thought disorganization, which are the 3 different types of psychosis that there are. And treatment, when I'm working with somebody who has Parkinson's disease, if the psychosis is causing them problems functioning or quality of life problems, then I really work to decrease as many of their dopaminergic medications, their Parkinson's disease medicines, as possible. And I try and just leave carbidopa, levodopa whenever possible. The other Parkinson's disease medicines that work on dopamine are very specific and powerful, and therefore they are much more likely to cause psychosis. If you're going to treat with a medication, there's a relatively medium-sized evidence base for using quetiapine or clozapine to treat psychosis in Parkinson's disease. There's a new medicine, pimavanserin, that is FDA approved to treat Parkinson's disease psychosis. There's no evidence that it's actually any safer or more effective than quetiapine or clozapine, and it's certainly much more expensive, so I don't use it very often. Depression, major depressive disorder, suicidality, often presents with sadness or lack of pleasure. There's a lot of people with Parkinson's who are preoccupied with death or who have hopelessness and executive functioning deficits, which are very common in major depressive disorder. Treatment, so the first, bupropion and nortriptyline are antidepressants that work on norepinephrine. And norepinephrine and dopamine is really the main neurotransmitters you usually want to target for depression in people who have Parkinson's disease. There's some very old studies of some serotonergic meds like paroxetine that showed some benefit, but there's not a robust evidence base about that. And serotonin and dopamine are inversely proportional. So the serotonergic medications can really cause unintended side effects for people with Parkinson's. Atomoxetine is a medicine that works on norepinephrine, and it is actually FDA approved for ADHD, but they just didn't get it approved for depression. It actually looks like an antidepressant if you look at the molecules, and there's no reason not to use it for that. Problem-solving therapy, cognitive behavioral therapy. If a person does not have moderate or severe cognitive impairment, if they don't have dementia yet, those therapies can be very helpful. There's some suggestion that maybe lithium and clozapine can help depression in people who have Parkinson's. Impulse control disorders, very common. And again, the treatment is minimizing dopamine, especially the anything that isn't carbidopa, levodopa. If you're going to treat it, we often treat impulse control disorders by adding things that work on GABA. So valproate or valproic acid, which is also called Depakine or Depakote, is a common medicine we use for impulse control disorders. There's an old medicine, carbamazepine, and a slightly more recent oxcarbamazepine that can be used. They have lots of drug-drug interactions, so you have to be very careful. You know, there aren't a lot of studies out there. You can use GABA or other things that work on GABA. So kind of many seizure medicines, for instance, might work on impulse control disorders. There's case studies, case series, not a lot of really no large randomized controlled trials. There's some suggestion that atypical antipsychotics might help with impulse control disorders. If it's specifically sexual, a sexual impulse control disorder in a man, then estrogen and progesterone might help curb some of that behavior. You have to do a good job of informed consent. Dementia. What we see with Parkinson's is slowed and trouble with memory retrieval. So with Alzheimer's, it's trouble forming a memory. With Parkinson's disease dementia, it's much more often trouble retrieving the memory. And the thinking being very slow, trouble making decision, and really decline in all of the executive functioning skills. So early on, you want to treat with memory aids, lists and things. That's not usually very helpful for Alzheimer's, but can be helpful in Parkinson's. You want to minimize the anticholinergic load. Any medication that has dry mouth listed as a side effect, you generally speaking want to avoid. And then ribostigmine is FDA approved for treatment of Parkinson's disease dementia. There's no reason not to use the other cholinesterase inhibitors either, because there's probably nothing special about ribostigmine except the company spent millions of dollars to get that indication. Anxiety and panic, you know, again, very understudied. There is some research suggesting cognitive behavioral therapy, but again, if somebody has cognitive impairment, that's going to be problematic. Serotonergic meds are how we treat anxiety in most people. You have to be careful with that in Parkinson's. MS. So, you know, there's multiple types, and neuropsychiatric symptoms. Demoralization was a commonly described one. which it's funny because I think that's the first time I've ever heard of that as a neuropsychiatric symptom. But depression is very common. You can actually see frank mania due to multiple sclerosis. Cognitive impairment is very common. You know, about 50% of people end up with cognitive impairment, and that can be in multiple different realms. Psychosis is not uncommon, and suicide attempts and suicide are pretty common in MS. So it's the depression is really a very key thing in this disease. And I think the fact that sometimes symptoms are unpredictable makes it harder to bear. So how do we treat those? Well, you know, there are lots of sophisticated treatments out there for MS these days. So an interdisciplinary approach is often quite helpful. You want to optimize disease modifying agents. You want to reduce doses of medications that might be leading to worsening of neuropsych symptoms, and you're going to have to take that on a medicine by medicine evaluation. You might want to use psychotropic agents, but you have to watch out for exacerbation of the other MS symptoms. And psychotherapeutic interventions can be helpful. And really, and this is key for all neuropsychiatric symptoms. There's this constant balancing of side effects of meds versus severity of symptoms. And so people will make a different choice depending on what's important to them. So depression, so the symptoms are kind of very typical for depression. And treatment is, you know, we don't think, as far as we know, that there's anything special about the type of depressive symptoms that people with MS get. The treatments are the same treatments we use for depression elsewhere, all the way from SSRIs to psychotherapy to lithium and ECT. Mood lability, which may resemble what we see in bipolar disorder, is particularly prominent in MS. And the symptoms, again, the presenting symptoms look very similar to mania, and the treatment is very similar to how we treat mania. And so it is one of the rare things where we do actually recommend benzodiazepines as a treatment. You have to be very careful with those with older adults, but sometimes in MS, they are quite important. And depending on where you are in your disease progression, you may be exposed to a significant number of steroids, and steroids have their own set of neuropsychiatric symptoms that you have to attend to. Psychosis, again, there's nothing particularly special about the kind of psychotic symptoms we see in MS. They're similar to the psychotic symptoms we see in other diseases, and the treatments are likewise the same. And you have to assess how a person's MS symptoms are, as well as the severity and quality of life impairment from the psychotic symptoms, and do a risk benefit, you know, what's most important to this person kind of decision tree. Anxiety, the same thing. You know, there's nothing particularly special about it, and the treatments are the same kinds of treatments we use with anxiety everywhere else. Just a word about pseudobulbar affect and euphoria. You know, there's a company that developed a medication for this that has been in a lot of trouble nationally with the regulatory agents, because they sort of went out and did lots of education around this. This is pseudobulbar affect and euphoria is most often seen in people who've had a stroke. You can see it in MS upon occasion. And then there are a number of different things that have been used to treat it over time, and what one person responds to will really vary person to person. But the reason that the last thing on that list, which is the drug that got into so much hot water with the Federal Drug Agency, is the medication that was used to specifically target this one symptom. Huntington's disease, well, 98 to almost everybody with Huntington's disease, if they live long enough, will have neuropsychiatric symptoms. And the kind of symptoms they have, and I probably didn't put these in a very good order on this slide, but dysphoria up to 70%, disinhibitions, impulsivity, aggressive behavior up to 70% of people. Anxiety, apathy, psychosis, and irritability, 65% of people with Huntington's have significant irritability. It is a disease that will lead to dementia if you live long enough with it. It has one of the highest rates of suicide compared to any disease outside of major depressive disorder and schizophrenia. And symptoms that seem to precede that in people who have Huntington's are anger management and extreme impulsivity. Ask about it, you know, asking about suicidal thoughts is not going to cause somebody to have them. And many of our patients, many of our peers, and many of our neighbors have suicidal thoughts from time to time. That in and of itself isn't abnormal, but if somebody starts to think about it quite a bit and it's, you know, weighing on them, then that's when it really can become a problem. And for Huntington's, what we try and do is work on triggers for anger management, reframing interactions, working with the people around the person on expectations so that people aren't expecting too much of the person with Huntington's. Because as the disease progresses, you know, less and less is under their control. Apathy can also be pretty common. And again, what I think you might have noticed is that many of these treatments, so the principal presenting symptoms and the treatments are not unlike how these symptoms present in any other illness, in any psychiatric illness. You know, there really is quite a bit of overlap between neurology and psychiatry. And so what you want is a person-centered treatment plan. You want to really do the best job you can on defining the symptoms, getting a target symptom, and then doing medication trials in matching medicines to the symptom. And then you can look up how to dose things. That's unfortunately far beyond the ability of a 1-hour presentation to really go into how to actually dose medications to treat all these symptoms. But there are articles out there and there is guidance out there. Seizure disorders, again, cognitive problems are common. Mood problems are quite common, as is suicide. Anxiety and psychosis are not uncommon in seizures. And one of the first questions you have to ask is, when are the symptoms occurring? Are those symptoms occurring right before somebody has a seizure? Do they occur during the seizure, or do they occur in what we call a post-ictal state right after the seizure? And also, are these symptoms related to any of the anti-epileptic drugs that the person is on? Because many or most seizure medications work on GABA, which is kind of like a blanket on the brain. And that those medications can have significant neuropsychiatric side effects. So, since I can't use this time to teach everybody to be an expert, what I'm going to just really talk a little bit about in the next couple slides here is a paradigm for how to think about using medications when you have a set of symptoms that are causing your patients and their families distress and quality of life impairment, or even putting people at risk. You know, how do you think about a medication intervention trial? And here's what I recommend. I think you want to really define, prior to trialing a medicine, you want to define how often does the symptom occur, how long does it last, when does it occur. You need to know, is it a natural part of this illness, or does it seem like it's a separate part of a separate psychiatric disease, for instance, not related to the neurological disease that the person you're working with has. You want to define for both yourself and for your patient what changes you're hoping the medication will have, and you want to track them. And you also, people want to know, when do you expect to see changes? What are the common side effects? I didn't write this down, but what are the serious side effects? When you do an informed consent discussion, the key thing is really to review common things so people don't just quit medicines. Because things happen and they didn't expect it. But you also want to review, of course, anything that could cause significant or life-threatening side effects. And then you want to follow up. And depending on the severity of the symptoms, you want to follow up in a week or 2 week or weekly, and you want to track changes. So when I'm doing this, I tend to start with whatever symptom is either dangerous to the person or others, or what symptoms bother the person the most, because those are the things that the person is going to be most motivated to change. And so, and sometimes what I often do is I have people track 1 or 2 things, and I just have them rate on a 0 to 10 scale. And I will define that. So if 0 was feeling like you were ready to throw yourself off a bridge, and 10 was feeling really great, like the happiest day of your life, where would you put your mood right now? And if 0 was feeling so panicked and your skin was crawling and you just felt like you were losing your mind or going crazy, and 10 was no worry, no anxiety, just sort of handling life and what happens as it comes, where would you rate your anxiety today? So I tend to, and it's hard to get people to rate more than 2 things. And I actually track that and have been able to use those numbers over time to tell whether or not medications are helping. So for instance, I had someone who I was tracking mood changes with, and their mood, when I started working with them, where 0 was the lowest, was 1 to 2. And when I had worked with them and tried some medication changes, we got up to a point where their mood was a 3 to 4 most of the time. Now, is that a good thing? No, that's not. But this is a person who had failed 10 different medication trials before they came to see me. So actually doubling their mood, going from a 1 to 2 to a 3 to 4, it was not what we hoped for, but it was significantly better than this person had had in decades in their life. And the only reason I was able to do that was because I tracked it over time. And I did this. I did an off-on-off trial for that particular person. For that particular person, sadness and just trouble motivating themselves was the major target problem. And we weren't totally certain that this medication trial that I had done was helping her. And so her mood was better, as tracked by this very simple tool of self-rating. And so we stopped the medicine, and within 3 months, she returned to that 0 to 2 for a mood. So we restarted the medicine, and again, her mood did improve. Now, did it improve, like totally improve? No, absolutely not. Would it have been great if I had gotten her to a point where her mood was a 6 to 8 or 9 most days? Yes, that would have been great. But again, this was somebody who had really, people had tried to help her for decades and had not been able to help her. And so we were able to improve her mood, and we were able to show with this on-off-on trial that the improvement appeared to be related to the medication. And that's what I used to document in my notes. I recommend indefinite treatment with this medication for this person and for this symptom, because she really was kind of at the end of her rope when I met her. The on-off-on trial, when do you want to do that? When does that make sense as a strategy? Well, I think that makes sense. It made sense in that case that I just discussed, because if I just said to her, how do you feel? The answer was always the same. It was always, I feel bad. I don't feel good. I can't do anything. So asking her a general question wasn't helpful at all. And it was very difficult to tell. But with the on-off-on trial, I was able to establish, at least to my satisfaction, that this was a medication that was helping this person. And the side effects she had were very mild. And so I thought it was definitely worth it, because even though her mood was still not great, it was no longer unbearable every single day. And for that particular person, I really felt like that was the best that we could do. So that's sort of how I think about things. And so, the considerations for a medication intervention trial and how do you set it up, it's important to think that through, get a good informed consent, and then follow things over time. You have to know what you're looking for. And then if you ever are wondering, are my medications making a difference? You can do an on-off-on trial. There are times I would never recommend that. So for instance, I've taken care of 3 men who thought that their wives had been substituted by somebody who looked and sounded like their wife, but wasn't their wife. And these 3 men, totally separate years, counties, and individuals, tried to kill their wives. And so that is not, I would never recommend an on-off-on trial for any of those, for that kind of a symptom. That is somebody who I would feel quite comfortable if I was able to, and I was able to treat them with medications that made that symptom go away. And they all 3 did have a neuropsychiatric disease. They didn't have kind of quote unquote psychiatric illness. We were able to treat that symptom. Unfortunately, one of those was not under my care continuing. And so after about a year of doing well, their outside psychiatrist who was following them, they and their family wanted to go off the medicine because they didn't want to be quote unquote controlled by medicine. So they went off the medicine. And of course, as one could predict, 4 to 5 months later, he again tried to kill his wife, and he almost succeeded. Fortunately for her, he didn't succeed. He did come back to me. We did retreat him with the same medicine and got his symptoms stabilized. But because of this gradual dose reduction and forced trial off of medicine, he then, he was never able to go and live with his wife again because she just felt like she couldn't trust him, even though it really was something that he and the family and the psychiatrist had all agreed, well, we should just, retrial this. So there are times where I personally believe it is quite questionable to consider an on trial. But there are many other times where if you're not sure a medicine is helping, this can be very helpful. This can be a very helpful way. Now, a lot of times people will do this by themselves, and you don't have to do it. People are on a medicine, then they take themselves off, or they move and they don't have a new prescriber, and they go off the medicine and the symptoms come back. So if a person has done an on trial all by themselves, then I think, the experiment has been done and you don't really need to run it again. That's sort of how I view it. Not all neuropsychiatric symptoms are severe enough to need treatment, but again, these are the symptoms that tend to have the most impact on quality of life. And so that is the reason that we treat them. All right, so I did my best to leave time for questions, and then I also have some references at the end of the slideshow. So let's see if I can figure out how to see the question bar to see if anybody has any questions.
Dr. Nash, we have a question from Brianna.
Okay.
When you're considering the care team for an individual, how many people in that care team or what key members of that care team do you think it benefits the patient to have involved around being educated on these side effects and risks and benefits so that multiple people have eyes on whether the risks outweigh the benefits?
So the people to have on your team, I think, depend on the disease you have and how significant the impairment is. I think if a person, I think a basic team is the provider who's basically following the neuropsychiatric illness, and then if you need an external mental health provider, a psychiatrist, or a psychiatric nurse practitioner who's experienced in that area. I think occupational therapy can be an extremely valuable member of the team because their job is really doing thorough assessments of functioning and helping identify what a person's strengths are so that you can really design a person-centered care plan. I think a therapist or like a licensed social worker or a psychologist, if a person isn't having significant cognitive impairment, can be helpful. I think a social worker can be helpful if there are family dynamic issues or if caregivers are having distress. And I think caregiver support is always important, and caregiver education. Pacific University asked a great question. When doing an on-off-on trial, is there a special way to distinguish between a discontinuation syndrome and a return of the original symptoms? Well, I can tell you how I do it. And I realize I sort of have a special kind of practice because for the last 15 years anyway, if you come see me, you almost never have a simple, straightforward problem. So the people I have taken care of have really hard problems and have almost always failed multiple other people helping them. So the people who come to me, generally speaking, are either very sick and endangering themselves or others, or they are very motivated because they are so distressed, or their family is very motivated and bringing them because the situation is so distressing. So I have a special group who's really motivated. But the way I do it is I look at how long have the symptoms been going on and what is the long-term goal. And usually the long-term goal is we want to see the quality of life the best it can be, and we want the symptoms under control. And so because of that, I think the best way to do any sort of tapering is slow. And so if somebody had severe symptoms, I will taper them off usually over like a year. Obviously that's somebody who's on a, not the lowest dose possible, but somebody who's on a medium or high dose. And if you are tapering that slowly, you're not going to see a discontinuation syndrome. I think the major problem, the reason we see things that are discontinuation syndromes is people don't take into account the timing of what's happening in the brain. When I give you a medication that affects neurotransmitters, for instance, let's say I gave you a dose of citalopram or Celexa, your serotonin levels are going to be normalized in like 24 hours in the brain synapses. But the medication doesn't work that fast. And that's because there's something else happening in the brain. Those serotonin molecules are affecting serotonin receptors, which are then affecting circuits of electrical activity in the brain, and over time change the way those circuits are working, and that's what affects the symptoms. And so I think when people, my sense is people do like a 2-week taper or a 1-month taper, and that is way too fast for the brain. I mean, if it's an emergency, yes, that's when you want to, you might want to do something like that, and you might want to do it in a hospital. But if it's not an emergency, what is the hurry? Because what we really want is long-term stability. And so I'm a big fan of doing things very slowly. And I think if you do it very slowly, you have almost a 0 chance of a discontinuation syndrome. I think what happens is people taper people off of medications far too quickly. Can we have a copy of your slides? Yes, I think, oh, I didn't put my little copyright notice on them. So I'll put that copyright notice and then they can send them out. Have you received any feedback on the outcomes of counseling or talk therapy interventions with various conditions you've presented? And if so, what do the outcomes look like? So I have seen benefit. The benefit often for these neuropsychiatrics diseases, multiple sclerosis, Huntington's, Parkinson's disease, often you want to do therapy with the person's whole support system and the person. And what I find is that working with the support system for the person is often at least as important, because if they change the way they react to a person, that will help the person be able to deal with their brain problem, their brain not working right. And so I think one of the key things is knowing when somebody's brain isn't working well, you don't want to ask their brain to be responsible for too much. That being said, if a person doesn't have significant cognitive impairment, so I've seen problem-solving therapy and cognitive behavioral therapy help people with early Parkinson's disease, for instance. Those two types of therapy can help with decision making. They can help with depressive symptoms, and it appears that people benefit the same way they benefit from treating other psychiatric diseases. So I think the outcomes tend to be decreased symptom severity and increased ability to cope with the changes. But whenever there is cognitive impairment, I do strongly recommend therapeutic interventions and support groups for the caregivers, which could either be professional caregivers or family.